Oh, well, hello there. I'm Dr. Michael Wansbrough, and welcome to the Orthopedic Rehabilitation Institute. And you've probably been sent here because of several different kinds of musculoskeletal issues, but today we're just going to talk about radicular low back pain, which means pain that goes down your leg from your back, usually because of an irritated nerve. Now, let me show you what I'm talking about with my friend. The spine here. So this is your back, this is your front, and this is your tailbone area. It's called your sacrum. And what happens sometimes is either because of a bulging disc pushing backwards or a herniated disc, or sometimes because of inflammation of these facet joints that link your spine together. As you can see, if you're moving around, they can grind and cause inflammation. Like any joint that's overpressurized for long periods of time can cause inflammation and arthritis. So between these two issues, it can conspire to decreasing the space of where the nerve roots come out. They come out of these holes here. And if they're being pinched, that can cause pain that can go down your leg, resulting in what's commonly known as sciatica, but can also involve other nerves apart from the sciatic nerve. So what do we do from that? Well, we definitely use a holistic approach to management, which includes physical therapy, which is a cornerstone of treatment. And not all physical therapists are created equal, and often physiotherapists or chiropractors are used to treating young athletes and may be a little over aggressive. And when it comes to chronic pain patients, they may try to put you through your paces more aggressively than what you're ready for, and that might result in more pain, and then you decide, physio or chiropractor just caused me more pain and I'm not going to go back. But it's important to feed back to your provider whether it worked or didn't work, and then they can adjust the exercises accordingly. So core muscle strengthening, what's called the Stuart McGill Big 3 back exercises, which you can look up on my website, painnopain.com. I have a link to these things. McKenzie exercises, but active physical therapy is what's important, not passive. So a little bit of passive, which means you lying on your tummy and they do things on your back, can be okay. But you also want to engage in active physical rehab, which is about core strengthening, building, learning exercises that you can do at home on your own eventually, and engage in regular back rehab. So that's the physical therapy side of things. Then there's medications. Generally medications aren't great. A lot of them come with side effects. Some can be quite effective in some people, and we'll talk more about those at another time. And then there's pain psychology, which is important. So that's part of the biopsychosocial approach to pain management. And that's another discussion. There's a great book called The Way Out by Alan Gordon, which discusses this in detail. And it doesn't mean that the pain's just all in your head. It means that the nervous system has become sensitized after being exposed to chronic pain for so long. And that is an important target for treatment. And then nutrition is important, so anti-inflammatory foods, and a lot of foods we eat are pro-inflammatory. So looking at the Harvard Health Guidelines, for example, of what is inflammatory, what's anti-inflammatory is very helpful. Again, I have a link on my website to nutrition and weight loss, keeping fit and keeping the stresses off the spine is important. So you can imagine if you're heavier, that's going to create a bigger load on the spine. So that's a really big part of management. So nutrition is a super important part of rehab. Finally, what we specialize in here is image-guided injections. So this is not meant as a cure, it's meant as an aid to getting on with all these other things. Sometimes you have too much pain and you're like, I can't even move. How am I supposed to do physical rehab? Well, this is where we come into play with our injections. So what we do for sciatica type pain or pain that goes down your leg is something called a caudal epidural. And caudal means tail in Latin, and so what that means is in the tailbone here area, there's a space called the caudal space. And what we do is with the ultrasound or fluoroscopy machine, we identify that space and we put a little bit of freezing in around the area. And we do that in our image room with a nurse who checks your blood pressure and gets you all set up and cleans your tailbone area and your back. And then I inject some cortisone into the space, and it washes up underneath this bone. This is called the sacrum, and it washes up under this bone, and it then bathes the nerves that come out of the spinal cord in that anti-inflammatory. So that decreases inflammation and helps to bring your pain level in your leg from where it is here down to something more manageable. Don't expect it to be 100% gone, but it should become more manageable. Common questions, and so what you feel is usually pressure. And it takes about a minute or two to do, and we go slowly, or to make sure that it's tolerable. So again, it takes about a minute or two to do, and then sometimes after that's finished, then we go up around where the nerve root is coming out, and we put a little bit of cortisone around there as well. The whole thing takes about 5 minutes. So one of the questions often we get is, well, how much pain, when does the pain relief start? How long does it last? And generally the freezing part of so we inject cortisone and freezing together, and the freezing part works like in the dentist office pretty quickly. So you might feel pretty good after the injection, and you have to be careful not to overdo it. I mean, on one extreme, I've had a patient who went and played 18 holes of golf afterwards and wondered why he wasn't feeling very well the next day. So that's a bit of an extreme case, but usually you feel better after the injection. But then the freezing wears off, and then the cortisone hasn't started to work yet, so you might feel back to where you were before. So don't despair, because the cortisone will start to work. Usually it takes a day up to about 4 or 5 days to start to work, usually a day or two, and then that starts to decrease the inflammation in the area and you start to feel better again. So typically, we bring their pain level, which starts off about here and hopefully comes down to a more reasonable level, more manageable level, and cortisone lasts about 2 or 3 months, and then the effects basically wear off, and your pain may start to come back if nothing has changed in your spine, and occasionally we have to repeat things again. But hopefully it's been giving you a window of opportunity to get on with the physical rehab side of things, to explore the pain psychology, to work on nutrition, and to make some progress. So it provides that window of opportunity to feel somewhat better. So what are the risks of this injection? Well, anytime you have a needle, there's a risk of infection anywhere in the body. The risks are very, very, very low because it's a very sterile procedure. And up until this point, I've never seen an infection, but it's a potential risk. Cortisone can sometimes make you feel a little hyper for a day or two. It's not dangerous, it goes away. I had one patient say she read 3 hours of philosophy afterwards. Okay, maybe that's another extreme case, but typically that goes away after a day. Sometimes 5% of people may have a flushed flushed feeling in the face. So if you look in the mirror and you see that your face looks flushed, don't go to the emergency department. It's okay, it's gonna get better. Good. So cortisone itself has some effects on the body. It can raise your blood pressure temporarily. It can raise blood sugar if you have diabetes. Talk to your doctor about that. And it can increase glaucoma risk if you have glaucoma. If you have too much cortisone, it can cause problems with thinning of bones and tendons over time. So that's also an important thing to think about. Now, generally, the risks for those things increase with the amount of cortisone that you have and the frequency that you have the exposure to the cortisone. So we're very careful about keeping a track of how much cortisone we use and how frequently we use it. The goal is to try to improve your function and to decrease your pain so that you can have a better quality of life. Let's see, what else can I say about cortisone? There's more information on the website painnopain.com under injections and cortisone. There's quite a list of explanations about the benefits and the risks of cortisone. Other risks, nerve damage, unlikely. It's always a potential risk. Injection into a blood vessel is a potential risk, but very rare. And usually the symptoms of some dizziness, lip tingling, usually pass after about 10 or 15 minutes, but it's again very rare. Again, very rarely you might have a weak leg for a few hours because the freezing goes around one of the nerve roots and can make that leg feel weak. It happens maybe 2 or 3 times a year, very rare, and generally resolves with just some water and just waiting for about 15 or 20 minutes in the clinic. So that I hopefully can encapsulate what a caudal epidural is, what it's used for, potential risks and benefits, and if you have questions, of course, ask your doctor. Thank you. Okay, let's go for a tour. I'm going to show you where we do our interventions. Come on with me. Okay, these are pictures on the wall which I find very scary. I wish we could replace them with nice relaxing, peaceful wellness pictures, but I'm outvoted every time, so come on with me. Okay, take 75. Okay, come with me, and I'm going to show you the ultrasound room, and it's right in here, and we have our wonderful staff here, and this is our ultrasound machine. So you will lie down here, the nurse checks your blood pressure, make sure everything is nice and sterile and clean. We're not going to do that right now. We wear WAPGAP masks and gloves, of course, everything is pristine. And then what we do is we look on the back with our ultrasound. Why is this so jammed? There we go. And with the ultrasound probe, we look at your back and we can see your spinal anatomy. And then we find the right spot and we do the injections depending on what your problem is. It's a very efficient and pretty quick procedure. And then the nurse checks your blood pressure again and you're good to go.